Hi there, I'm Dr. John McGann. I'm the Director of Ultrasound and Abdominal Imaging from the University of California at Davis. Our hospital isn't in Davis, California, but actually in Sacramento, California. I've been there for over close to 30 years now. I'm going to talk to you on a topic about ultrasound in the fetal head. So I'd like to get started with my topic. I'm going to talk to you today on ultrasound of the fetal head. A lot of different portions to talk on here. We could talk about ventricular measurements, etiology of ventriculomegaly, ventricular cysts, vascular malformation. However, I'm going to stop at that point. I'm not going to talk about the posterior fossa. So what we're going to talk about is mainly the supratentorial fetal brain. First topic I'd like to talk about is ventricular measurements. There's a rule out there, it's the 10 millimeter rule. I'd like to go back and talk a little bit about how that 10 millimeter rule got started and basically what this 10 millimeter rule means. First publication on the width of the lateral ventricle was done by Cardozo out of San Francisco, and he came up looking at the atrium of the lateral ventricle. So he would look at that atrium, came up with 100 fetuses, had a mean of 7.6 millimeters throughout pregnancy with a standard deviation of 0.6 millimeters. This is fairly interesting because what he did, instead of taking 2 standard deviations, as many individuals do, he took 4 standard deviations and came up with a value of the upper limits of normal of the ventricular atrium of 10 millimeters. But in fact, like most studies do, if he would have taken only 2 standard deviations, he would have come up with a measurement of 9 millimeters. Second study that came out, and there were a couple other studies that came out, was done out of our institution. We did our study a little bit different. Instead of taking 100 consecutive fetuses, we took 500 fetuses that were examined by sonographers. So these are a different pool of individuals that looked at the fetal head. Our mean was a little lower at 6.6 millimeters, but our standard deviation was a little higher at 1.4 millimeters. We picked 2.5 standard deviations from that mean to pick our upper limits of normal, and we came up with the exact same measurement of 10 millimeters. However, just imagine for a moment we would have taken 4 standard deviations and we would have had a value for the upper limits of normal of the width of the atrial fetal ventricle atria of 12 millimeters. So what would have happened if somebody would have gone ahead and we established instead of 10 millimeters a rule of 9 millimeters or 12 millimeters? First of all, I'd like to emphasize that no one value separates the normal population on the left from the abnormal population on the right. So if we pick 10, that does not completely separate these populations. In fact, if we look at this, these populations do in fact overlap. So there's no doubt the width of the lateral ventricle of some abnormals may be 9, while some of the normals may go above that. Well, what would have happened if we decreased our upper limits of normal to 9 millimeters? Certainly, we would have increased our sensitivity by minor increased detection of abnormals. However, this would be at the cost of decreased specificity, and what we do is we'd have major inclusion of normal fetuses. If you look at different series, certainly this would cause a lot of maternal and paternal anxiety, and in certain series where there is very mild ventriculomegaly, this could lead to termination of a completely normal fetus. What would happen if we increased our upper limits of normals to 12 millimeters if we would have accepted 4 standard deviations as in our study? Well, certainly our sensitivity would have decreased. So there's certain abnormals that potentially we would have missed. However, we would have increased our specificity, so certainly we would have decreased the inclusion of a number of normals. Well, let's look for a moment really what ventriculomegaly means, especially at that borderline ventriculomegaly between 10 and 12 or between 10 and 15. If we look at isolated borderline ventriculomegaly in which there's no other abnormality detected in the fetus, we see and we stratify these between 10 and 12 and then between 12 and 15. We see that as the ventricles get bigger, the abnormal outcome increases. So it's 9% in those ventricles from 10 to 12, and abnormal outcome was increased to 24%. So as the ventricles get bigger in the second trimester, certainly there is increased rate of abnormal outcome. Now a couple of questions I have. Do male fetuses have bigger brains than female fetuses? Second question, do all males think they do have bigger brains? And third question, do male fetuses actually have bigger ventricle than female fetuses? Well, the answers to the first is no. The answer to the second is definitely yes, but the answer to the third is very interesting. In fact, if we look at male fetuses, they do tend to have slightly larger ventricles than female fetuses. So what does that mean? Well, what it translates into is the rate of abnormal outcome with borderline ventriculomegaly is greater in female fetuses as compared to male fetuses. So if you have a male with a ventricle of 12 millimeters, that may in fact be more likely to be normal than if you have a female fetus with a ventricle of 12 millimeters. And in fact, in this study, if you looked at that, the rate was 5% for males with an abnormal outcome compared to 24% in females with an abnormal outcome. Well, let's look at several pitfalls in looking at the ventricles. First pitfall is the upside ventricle. Now just think of any study that we would do and we'd only look at one half of whatever anatomical structure we're looking at. So in the case of the fetal brain, most of the time, unless that fetus flips, we're only looking at that downside ventricle. Well, back in 1990 and a couple of papers after that, they developed, Mike Cronin, one of our sonographers out of UC Davis, developed a technique for looking at that upside ventricle. If you angle the transducer through this thinnest portion or the temporal portion of the bone, you'll be able to see that upside ventricle. It looks a little bit different, but what we found when we did another study on 500 fetuses, about 1% of the time we detected things on the upside ventricle or the upside cerebral hemisphere that we did not detect with a normal view. So normal view seen on the left, and we do our angled view and we identify a large cyst that was invisible with our routine shot of the fetal head. Another pitfall. In fact, if you look at the fetal cerebral ventricles or the fetal head at one point in time, say the 20 weeks, you really need to look at that ventricle later on if in fact you're going to re-examine that fetus for fetal weight, because the ventricles are very dynamic. If in fact you have a ventricle that's 12 millimeters, usually it decreases, but on occasion they certainly increase. And even if you do have a normal size ventricle, you should always look at that ventricle later in pregnancy. Such a case, posterior fossa, looks pretty good. Shot in the fetal ventricle, this is at 20 weeks. That ventricle measures 7 millimeters. Nobody here would probably advocate a follow-up. However, 36 weeks, this is the same fetus. We see the ultrasound of the fetal head, a sagittal view of the fetal head, MRI postnatally, another MRI, T1 weighted postnatal, and this turned out to be aqueductal stenosis. In fact, we gathered several very interesting cases in which during the second trimester or early in pregnancy, the fetal brain, the fetal ventricles looked normal, but later on in pregnancy, they turned out to be abnormal. These are 6 of these different cases. 2 of them turned out to be normal at 20 weeks. The one I showed you later turned out to be aqueductal stenosis. 3 of them turned out to be hemorrhage later in pregnancy. One case turned out to be normal early in pregnancy, later on was porencephaly. I'll show you a couple of these cases during my talk. Here's another potential pitfall. What is the diagnosis here in this 14-week fetus? Certainly looks like this may be a dilated ventricle, but what we look for is in this case, there is no dangling choroid plexus. We get a hypoechoic cerebrum, and we see a line here probably corresponding to the subarachnoid space. This is so-called pseudohydrocephalus. Here's another case. We're looking at the ventricle. We have it measured, but you look at this other hypoechoic structure, which is the cerebrum. But we can identify this is pseudohydrocephalus because we note the ventricular walls here, the upper, the lower ventricular wall. We note, again, there is no dangling choroid. Well, finally, after just talking about the ventricular measurements, let's go on to particular etiologies of ventriculomegaly. When we talk about ventriculomegaly, what we're really talking about, the ventricles are enlarged. It really doesn't tell us the specific etiology. So there may be an obstructive phenomena such as hydrocephalus, there may be maldevelopment, or there may be a destructive order of the brain in which the ventricles do enlarge. If we have massive CSF collections, and it looks like there's large ventricles, you think of three things. One is a massive obstructive hydrocephalus. The other would be a lobar holoprosencephaly. The third would be hydranencephaly. Let's take for a moment and separate out these three separate entities. Entity number one, we look here, we have a midline phelps. We look, these are two separate cases, one's more severe than the other. We look at the case on the bottom, we see there's dangling choroid, and we look here, dangling choroid, we have cerebral tissue, there was a normal face. This is a case of two cases of hydrocephalus. Case number two, abnormal face over here on the downside with a midline cleft. There is a monoventricular cavity, and what we also see, there is fused thalmi. This is alobar holoprosencephaly. Alobar holoprosencephaly almost always is associated with a very dismal prognosis, has associated facial abnormalities, and is often associated with trisomy 13. The final entity here we take a look at, we see a midline phelps. We see no cerebral tissue. There was a normal face. And this is hydranencephaly. This is probably secondary to bilateral internal carotid artery infarcts and or occlusions. We also note the thalmi are there, but they tend to be separate rather than fused, as with alobar holoprosencephaly. Well, things are never as simple as they seem, and there's often other more complex abnormalities. Let's just take for a moment hydrocephalus, and there's a number of different etiologies. We do not have time to go through all these, but we'll take for a moment and look at a few. Here's such a case where we have three separate portions. The head on the left that shows ventriculomegaly. Over on the right upper hand slide, we show the posterior fossa that looks compressed or small. And then we have a shot, the third image on the bottom, through the spine. This is so-called lemon head, banana type deformity associated with Chiari-2. So when we do an ultrasound, we go ahead and we do a complete evaluation, and often we can come up for a specific diagnosis, as in this case. Other etiologies could include a large cisterna magna, whether it be from an arachnoid cyst, whether it be from Dandy-Walker complex, which has a lot of variabilities from just minor inferior vermian agenesis to this Dandy-Walker malformation. These could be potential etiologies of hydrocephalus. This is an MRI, and in this case, there's severe cerebellar hypoplasia in this case, as well as vermian agenesis. Next, let's talk about maldevelopment as an etiology of ventriculomegaly. First, we look here anterior, posterior of this fetal head. We look and we have colpocephaly. But we also look that the ventricle is parallel to the midline, the frontal horn is not dilated at all, and there is a prominent interhemispheric fissure. This is what a normal fetal head MRI looks like. I'd like you to look for a moment and look at where that frontal horn lies. Look at the trigone, it's barely dilated. Now, take the case that I just showed you, and what you have is colpocephaly. You have 3 parallel lines, and this is a case of agenesis of the corpus callosum. This ventricle has often been termed the teardrop ventricle. If we took this cartoon of the face, put it on its side, we can see the teardrop ventricle both on ultrasound and looks identical on MRI. This is the teardrop ventricle with that ventricle being parallel to the midline in agenesis of the corpus callosum. Once we see one abnormality, it's important to make sure that we can come up with a specific diagnosis. So in this case, we went ahead, we did MRI. This is a T2-weighted image, and what you see is behind the orbit another cyst. So you see the orbit in front as a cystic structure, but you see a cyst behind that. This newborn MRI again showed this large orbital cyst that caused proptosis of that eye. Here's a gross image of that showing the proptosis of one eye. This turned out to be a Cardi syndrome that we could diagnose by ultrasound. Agenesis of the corpus callosum, often associated with chorioretinopathy, mental retardations in only a few cases. But if you see agenesis of the corpus callosum, think of other syndromes, as in this case here. Next, I talked to you about holoprosencephaly, but I only showed you the most severe form of alobar holoprosencephaly. There are other forms. The face predicts the eyes, and before we had ultrasound, pathologists would look at the face and say whatever the face had would predict, or the face would predict the brain. So if they took a look at the face, and it would predict what the brain shows. So the eyes are really key here. So if there is cyclopia, midline cleft, there is a huge proboscis, that often was associated with some type of holoprosencephaly. This is a case of a monoventricular cavity associated with a cleft lip. This is not as severe as the alobar type of holoprosencephaly, but this is semi-lobar holoprosencephaly. Prognosis is also very poor, often associated as well with trisomy 13. An abnormality that may be missed in utero unless we look at the region of the cavum is lobar holoprosencephaly, also called septo-optic dysplasia. In this entity, we have fusion of the frontal horns and we have absence of the cavum septum. Sometimes they may have visual impairment in these cases or developmental delay. So look very carefully for the region of the cavum. If you get a squared appearance up here with pointed frontal horns, think of lobar holoprosencephaly or septo-optic dysplasia. Well, finally under ventriculomegaly, let's move on. And let's look on to destructive phenomena within the brain. Here's a case, an ultrasound here, in which there is ventriculomegaly, but there's echogenic material around the ventricular walls. This is a CMV infection. You can see the postnatal CT in which you see calcifications surrounding the ventricular wall, and it's actually the brain destruction in which causes the ventriculomegaly. This has been called hydrocephalus ex vacuo, so that means the ventricles just occupy the space of the destroyed brain. Often the head circumference in these cases will be normal. Here's a case I'm going to show you again, a normal 20-week ultrasound. This is the 34-week follow-up. Remember, normal at 20 weeks. This is the 34-week follow-up, and what you see is a case of porencephaly. You see a large CSF collection that does communicate with the ventricle, and it is thought to be due to some sort of cerebral artery or middle cerebral artery infarction. You can see the posterior fossa is normal, the opposite side of the brain is normal. This is a destructive phenomena of brain. It may be difficult in utero with ultrasound alone to tell the difference between schizencephaly and porencephaly, but MRI in utero may be helpful to distinguish between these two entities. In this case, postnatal MRI, we can see that there is on the side of the porencephaly that there was a middle cerebral infarct. We also note that the ventricle is lined by white matter. Well, we have two other topics to cover in terms of looking at the supratentorial brain. Let's look at ventricular cysts. I'm going to give you two different cases, case A, case B, and I'm going to actually show you case C. So take for a moment 19-week fetus, couple of cysts within the ventricle, 29-week fetus, looks like we may have a cyst or two in the downside ventricle, and then another, let's say 29-week fetus, large cyst, maybe in the ventricle, we can't come up, or we don't really know. So you have three separate cases, all different diagnoses. So let's look at each three. Case 1, 19-week fetus, everybody knows about this choroid plexus cyst. They're benign in themselves. They occur 1 to 4%. They all resolve, or most of them resolve spontaneously. But what you have to watch out for is trisomy 18. So if you see this, be sure to check the biochemical markers in the serum of these patients, as well as do a very comprehensive level 2 exam looking at the hands, the feet, the heart. In this case, we go ahead and we looked at the hands. They never opened or closed. They were very clenched. We also looked at the heart. It may be hard to appreciate this, but there was an AV canal. And this case was a case of trisomy 18. Now, second case, case B, I showed you, doesn't look too much different, but this is at 29 weeks. Choroid plexus cysts, most of them are resolved by this time. This is in utero hemorrhage. It's often spontaneous, occurs about 29-30 weeks. Includes a number of different disorders that may cause this. Sometimes we really cannot find a specific etiology for this. And later on, you may get obstructive hydrocephalus because of the obstructive phenomena of the hemorrhage in these brains. A couple other cases, it's important to document. These are about 30 weeks, so you see a cyst here, and these are cases of in utero hemorrhage that finally developed into a cyst. Finally, the large cyst I showed you is neither of those. It, in fact, here's the CT after delivery, and this was an arachnoid cyst. So it's basically an arachnoid line in which there's cells that secrete CSF, and they get bigger and bigger and bigger. They may have mass effect. Usually they're not within the ventricles, but they're within the CSF cisterns. Anechoic, they look rounded, can occur in the posterior fossa, supratentorial brain is where they occur. So I've taken you through a list of different things, and the last thing I'd like to talk to you about in the supratentorial brain is looking at vascular abnormalities. Next case, we get a case here, we see sort of a tubular structure in the middle of the brain. What do you do next? Well, there's one of two things we can do. Certainly one thing we can do is we can go ahead here, we get an MRI T2 weighted, and what we identify is a signal void. This indicates blood flow. Well, what do we have with ultrasound? We have power Doppler, and in fact, you look here in power Doppler, this is a vena-Galen aneurysm. It's really an arterial venous malformation. These fetuses can develop hydrops, or after delivery they can end up with cardiac failure due to high output failure. They sometimes develop hydrocephalus, and they can be treated after delivery with different new endovascular techniques. Second case, 18-week ultrasound on the left, just pointing out the cavum, the posterior fossa is on the left side. By 30 weeks, I did a follow-up ultrasound. I actually did one in between at about 26 weeks. The one at 18 weeks, 26 weeks was normal. At 30 weeks, I see this large posterior fossa echogenic mass. So what is it? Well, I came up with two things. Could it be a tumor? Well, probably it doesn't have enough mass effect and it grew really fast in 4 weeks, or is it a hemorrhage? Did an MRI decrease signal intensity in the T2 weighted MRI? And what this happened to be is cerebellar hemorrhage. Very rare to have cerebellar hemorrhage. Usually you get it supratentorial, and most of the hemorrhages are from the germinal matrix. We really never found out the precise etiology. This was evacuated, and this fetus did well after that. All right, somebody's measuring up the ventricles in this case. So take a look at that 12 millimeter ventricle. Stop for a moment. This 20-week fetus, is this in fact being measured correctly? Well, look real closely because you see that choroid plexus. It isn't dangling, is it? So in fact, they're measuring almost the nearly entire cerebral cortex, and if you remeasured it, there's something extra-axial that's pushing the brain to the side. We waited 2 weeks, and the fetus flipped over, and now that, whatever it is decreased in size or decreased in diameter from 12 down to 7.5. What do we do next? We take a look at that. We do our MRI, T2 weighted image, and in fact, we see this structure here on the T2 weighted image, and this also turns out to be hemorrhage. This is a subdural hematoma in utero. Subdural hematomas are rare, but they're not uncommon to occur in utero. Laundry list of different things. Most of the time they're idiopathic, can be secondary to trauma. Other etiologies such as different coagulopathies may be the etiologies of these hematomas. These are important to diagnose as all other etiologies of hemorrhage in the fetus because they can occur with traumatic delivery, but they may, in these cases, they're not at all due to traumatic delivery. They occurred spontaneously for other etiologies. So what I've tried to do in the last 30 minutes is taking you through the supratentorial brain. I've gone ahead and looked at the ventricular measurements, why we picked 10 millimeters, what in fact happens if we look at fetuses with 10 to 12 or 10 to 15 millimeters. I've talked about different etiologies of ventriculomegaly. So there's a number of different etiologies of ventriculomegaly, from hydrocephalus to structural abnormalities to maldevelopment to actually destructive phenomena within the brain. Shows you a couple of different examples of different cysts that are close or appear to be within the ventricles, so you can be aware of some of these different mimics, and then talk to you about other vascular anomalies that you may see within the fetal brain. I hope you enjoyed this brief presentation of the supratentorial brain. Thank you for your time.